more presentation before lunch, and it sounds like there's a good representation out there in Zoom land from the Tar Heel State, because our next presenter comes from the University of North Carolina School of Medicine via Zoom. Dr. Scott Commins will talk about suddenly meatless, how tick bites are breaking the rules of food allergy. And so from the University of North Carolina at Chapel Hill, Dr. Scott Commins, please.
Thank you for the opportunity to talk today. I appreciate the organizers and the Central New York Lyme and Tick-Borne Disease Alliance for the invitation. And it's nice to get a talk in before the Tar Heels and the Syracuse Orange play this weekend, so no one has their feelings hurt at this point. I'm going to talk to you a little bit about the alpha-gal allergy and how tick bites cause a little different scenario than the typical tick-borne infection that we think about. Next slide. So here are my disclosures. I don't think any of these are incredibly relevant today. I will mention that we have a research grant with Revivicor, and they are a company that makes a version of pigs and therefore pork that doesn't have alpha-gal. We're not going to talk about that today, but I could see where that might be a conflict of interest. So I just wanted to mention that. If you'll go to the next slide. These are my scientific contributors. I don't like to wait until the end to point out the people who have really done the lion's share of the work here. And it also makes the point that doing science these days really takes a village. Next slide. So the story of alpha-gal really starts in the mid-2000s. And at that point, I was at the University of Virginia, and we were aware of two distinct forms of anaphylaxis. You'll click. It's definitely worth mentioning that Dr. Tom Platts-Mills, who is a thought leader in the world of allergy and immunology, was my mentor at the time, and a lot of this initial work took place in his laboratory. You'll click again. Once more. So initially, the story actually starts with an awareness that there was a series of allergic reactions taking place to a medicine called cetuximab, which is marketed as Erbitux. Click, please. So these reactions were anaphylaxis, but they were occurring immediately with initial intravenous exposure of cetuximab to patients throughout the Southeast. The reactions were consistent and regional, if you'll click again. And they were reported in the oncology literature, in fact, and shown here in the states highlighted in red are the places where oncologists were finding a high incidence of initial reactions to cetuximab. This was happening on first infusion. And if you really want to get an allergist's attention, tell us that something is happening the first time that a patient sees a medicine, because that means that the immune response is already present. So we were not at the time aware of why these patients would be reacting to a new cancer medication the first time they'd ever had an infusion with that medication. But it was a really striking observation and one that we were paying attention to. If you'll click again, one more time. Around the same time, we were actually hearing from patients at the University of Virginia Allergy Clinic that there were a few that they said, you know, I think I'm allergic to beef, and the reactions are unusual because they're delayed. And I stopped eating beef, because I was getting hives, and I would maybe eat a little more pork. And now I'm worried that I'm allergic to pork. And they would tell a similar story with lamb. And this was probably about 5 or 6 patients. If you'll click again. So these reactions, as the patients described them, to various forms of red meat were delayed. They were inconsistent. So patients would often be confused. They would say, I think it's beef. And I had a steak and I had hives in the middle of the night after having steak for dinner. And then I thought, well, it's probably beef. So I had roast beef to try it out and really convince myself that I should be avoiding beef. And in fact, nothing happened with roast beef. And so then I thought, well, it must not be beef. And then I would have a hamburger, and lo and behold, I got hives again. So these reactions were both delayed and inconsistent, but equally regional. If you'll click again. What we now know is that both the allergic reactions to cetuximab and these reported reactions to various forms of red meat were both due to the presence of IgE antibodies, which is the allergic antibody, directed against a sugar. The sugar is called galactose alpha-1,3 galactose, or alpha-gal for short. And this really, the connection between the two began to break a lot of different paradigms. The first of which is that it was an allergic response to a sugar. And you might say, well, how does the sugar get on the cetuximab medication? It turns out that that cancer therapeutic is actually made in a cell line that's a mammalian cell line. You'll go to the next slide. It turns out, click one more time for me. So all lower mammals, not humans, but all lower mammals make this alpha-gal sugar. And so the cetuximab medicine being made in a mouse cell line then meant that the cancer drug was in fact decorated with alpha-gal. So patients who had an allergic antibody there, when they were infused cetuximab, they were having an immediate allergic reaction. Equally, patients who were developing this new onset meat allergy were reacting when they would eat mammalian meat. So humans, it turns out, we don't have alpha-gal. Most of us make an antibody response to alpha-gal that is one of infection fighting or tolerance. But people who end up with the alpha-gal allergy, or alpha-gal syndrome, as I like to call it, AGS for short, those patients develop an IgE antibody to alpha-gal. If you'll go to the next slide. We felt like after the initial publication, which basically reported 24 patients at that point in time who tested positive by blood tests that have been developed for the alpha-gal sugar, but those patients were reports of these delayed reactions. There had been, in fact, no observable reactions to document that, in fact, this newly described allergy was verified and, in fact, delayed. So we, after the initial report, we took it upon ourselves to try to document the delay. And we used pork sausage and would do a pork sausage challenge. We used that for multiple reasons, but the two biggest were that because of the delay, we felt like we had to do these challenges in the morning. So we tried to find a food that people would have in the morning. And equally, it turns out that the fat content is incredibly important. So we needed a fatty food that people could eat in the morning. the pork sausage challenges usually involve 2 or 3 pork sausage patties. If we'll go to the next slide, this is a picture of one of our participants who was actually, by my mistake, released. And the reactions were so delayed that initially we thought, well, we must not have fed him enough pork sausage. And so we let him go. And this was actually a photo that his wife had taken about 7.5 hours after eating pork sausage. And if you'll go to the next slide, the reaction continued to progress, and he ended up covered in whelps with, incredibly itchy, inflamed skin. And we learned a lot of lessons in this food challenge, but not the least of which was that the reactions are really quite delayed. And in many instances, you're bored waiting around for things to happen. But then when they do happen, it can take off very quickly. If you'll go to the next slide, this is a participant who consumed meat as part of her food challenge, and in fact looked at us about 2.5 hours after eating pork sausage and said, "I really feel like I'm wasting your time." But fortunately, we had learned from the prior participant, well, let's just wait and see what happens. And sure enough, she developed hives and flushing, and ultimately developed gastrointestinal distress and required epinephrine. So we published this series of participants in 2014, where we really documented the delay. If you'll go to the next slide, I wanted to show you pictured on the right are the participants' palms and hands after eating pork sausage, almost 4 hours after. And I hope you can appreciate, even though I did a terrible job on the left of documenting her unaffected palms before the food challenge, I hope you can appreciate on the right that her palms are red, swollen, and they also were itchy to her. There is also a hive in her, basically sort of the elbow, the antecubital fossa, the elbow crease there, that she then develops complete systemic hives. But this palmar erythema and itching really becomes a bit of a hallmark for patients that develop the alpha-gal syndrome. So I just wanted to bring that to folks' attention. If you'll go to the next slide. We then began to collaborate both with the CDC and one of the main testing labs that was performing most of the national testing related to alpha-gal specific IgE. And I think you can appreciate here that those typical sort of southeastern mid-Atlantic states had a fairly high incidence of persons testing positive. But then over the ensuing years, from 2013 to 2018, we saw an increase in testing up and down the East Coast, but also extending now into the central U.S. And if you'll go to the next slide, this is a patient-reported website that anyone can access just by typing ZMAP alpha-gal into your search engine, and it will pull up this map. Where in the world is alpha-gal? And it allows people to basically crowdsource or self-document that they, in fact, have been diagnosed with the allergy. Next slide will show you the U.S. Specifically. I downloaded this in May, and you can, I hope, appreciate the preponderance of cases on the eastern central U.S. I think many of the West Coast cases might be due to travel, but there's probably an emerging story perhaps in some of those as well. Next slide. More recently, we've updated some of the geographic distribution, and numbers of alpha-gal related cases. I should have mentioned in the 2013 to 2018 data, that was basically about 34,000 cases, which was well more than we ever anticipated at that time. People used to ask me how many people had been diagnosed, and I would usually say 5,000 to 6,000. And then when we had the data from ViraCor in conjunction with the CDC from 2018, there were 34,000 cases. Then we recently updated this, and there was some media attention related to these updates this summer. This appeared in the MMWR and reported over 100,000 cases now total up through 2022. So adding roughly 80,000 cases to the 34,000 that we knew about. And if you'll go to the next slide, it'll show you the county level data that we have from ViraCor's lab testing. ViraCor becomes the central lab in the U.S. that was performing the overwhelming majority of alpha-gal IgE testing. This may, in fact, unfortunately, be the last time we get such robust national data, because the testing has now been decentralized. So local labs can now have availability to test, and we may not have as much sort of focused data. But I would bring to your attention, I think, a few things from this map. Number one, obviously, is the continued sort of mid-Atlantic, southeastern testing and prevalence of cases. But if you could visualize Long Island, the highest number of suspected alpha-gal syndrome cases were identified in counties within New York, which was Suffolk, at 3,746 suspected cases, and then another county in Virginia. In fact, Suffolk County is responsible for 4% of all suspected cases nationwide. I will say there's a slight caveat there, in that both University of North Carolina, where I am, and the University of Virginia, where I was, and Dr. Platts-Mills remains, we do our own internal testing in both institutions. So our data doesn't get reported in this national data. I think the other interesting thing I would bring your attention to with this map is the counties in Wisconsin and Minnesota. Those northern counties, we'll talk in a minute about the ticks, but it's just not clear to us that the same ticks are in fact present in those counties to the extent that they are perhaps in the east, the southeast, and the central U.S. So perhaps a bit of an emerging story there. If you'll go to the next slide, there was back-to-back reports in the MMWR issue. Sorry, next slide. Where, coupled with the report of over 100,000 cases, with basically an estimate of nearly 500,000 cases, because there's not that many allergists, testing is not necessarily readily available, and so the CDC epidemiologists estimate that there's probably 450,000 suspected cases of alpha-gal syndrome in the U.S. alone. And the juxtaposition here is that of a survey of 1,500 healthcare providers nationally found that 42% of them were not even aware of AGS, and another 35% were not confident in their ability to diagnose or manage AGS patients. If you dig even deeper, the story gets a little worse, because the providers who felt like they knew the most about AGS and had diagnosed the most cases, in fact, got the most questions wrong. related to the management of AGS. So we have this tremendous increase in expansion of cases, but we have a tremendous deficit in provider knowledge. So we have a lot of work left to do. If you'll go to the next slide. I basically just wanted to show this for folks connecting online or in the audience who may be working with others to diagnose patients or advocating for yourself for testing. The blood test is an immunocap, which is basically the IgE platform used internationally for looking at alpha-gal and other IgE-related responses. The allergen is O215, and the test can be easily found through your search engine by typing in alpha-gal IgE and scrolling down. So if you'll go to the next slide, just a couple of words about the way that this allergy presents and some updates on that. The original presentation, or that's what I call it, where people really report delayed signs and symptoms from eating typically fatty forms of red meat. They will report itching, hives, swelling, nausea, vomiting, diarrhea, loss of blood pressure, anaphylaxis, which is what we refer to, that sort of systemic allergic reaction. Many of those patients can tolerate dairy. Certainly some do not. More recently, though, we've found in working with Dr. Sarah McGill, who's one of the leading gastroenterologists in thinking about alpha-gal syndrome, is that there are patients and folks that we're aware of who basically get none of the telltale quote-unquote allergy signs or symptoms, and they have exclusively gastrointestinal issues. So they will report painful abdominal cramping, explosive diarrhea, profound nausea and vomiting, but they won't have hives. They won't have redness of their skin. And we call this the GI only, or sort of the GI presentation of alpha-gal syndrome. If you'll go to the next slide. Fortunately, this is now getting some publication, some awareness. The GI presentation, as I mentioned, will typically have abdominal pain, nausea, diarrhea. In fact, in our series of patients, 9 of them met criteria for diarrhea predominant IBS. And interestingly, they often reported nighttime awakening, and none of them recalled GI symptoms to red meat ingestion before they were diagnosed, and actually 75% recalled a tick bite. So there does seem to be a similar portion there thinking about the tick history. Unfortunately, the time from symptom onset to diagnosis was quite long at 21 months, and I suspect probably even longer in places that are not as familiar. Next slide. Fortunately, Dr. McGill and others have been quite vocal in raising awareness about this, and there's now a practice update for our gastrointestinal specialists, and we hope that this begins to bring increased awareness within the GI specialist community for the alpha-gal specific version of that. Next slide. This slide and the next one are included mainly so that we make the point that both labeling for alpha-gal and mammalian-derived products is, in fact, terrible. you think about tennis racket strings don't come with a warning that they come from the internal organs of cattle. And it's not that I'm not saying people with AGS can't play tennis. I think my point here is that the role of these cattle and pig derived exposures is much more goes much further than we ever initially thought. So if you'll go to the next slide, people with AGS can play football, they can play the drums. It's more that these products are just really beyond red meat, which is why I think of this as more of a syndrome than a food allergy. So there certainly is the food allergy component, but it goes well beyond that. And the management of AGS in many cases goes well beyond simply avoiding hamburgers and hot dogs. If you'll go to the next slide. In fact, this is a summary of the general exposures. In the US, we don't have very many gelatin-based plasma expanders, none to my knowledge, but if you're traveling or from Europe or Australia, they use gelatin-based plasma expanders quite regularly, and those would certainly be an issue for people with AGS. Many vaccines can contain gelatin as a stabilizer or inactive ingredient. Antivenom can be an issue for some individuals. There are hemostatic agents used during surgery that may contain mammalian ingredients as well. And you can see the others listed here. You know, we don't think as much about gummy bears or Swedish fish, but in fact, the gelatin-based exposures can be an issue for many folks. If you'll go to the next slide. Since we are in a tick-borne disease summit, it is appropriate that we talk about ticks and review some of the data related to how we believe that alpha-gal allergy is initiated. And we were not aware of tick bites as a cause for this when describing it initially. But in putting together the data over the past few years and finally culminating with a case control study, we're now convinced that ticks can cause this. So if you'll go to the next slide. This is just to remind you of the cases that are reported in the US just through this ZMAP website. So obviously just a snippet of crowdsourced data, but keep that in your mind. And let's go to the next slide. You can see the overlap between the distribution of Amblyomma americanum, or the Lone Star tick, and the cases from the prior slide. But obviously, just overlap doesn't make the story scientifically complete. So if you'll go to the next slide. Occasionally, we can have patients who come in with a tremendous number of larval ticks or seed tick bites. And again, I use this to raise awareness that seed tick bites can often look like and itch as greatly as chigger bites. So this is not uncommon. And if we go to the next slide, ideally, what we would love to see to kind of make the scientific connection between alpha-gal syndrome developing and tick bites is data just like this, where we have a patient who was diagnosed with AGS July 10th after reacting to pulled pork barbecue over the 4th of July. Her alpha-gal IgE is shown in orange. Her total IgE, which is just the sum of all the allergic antibody that her immune system is making, So we met in July, and she said, if there's anything I can do to help you or help the research, just let me know. And we usually tell patients, if you get a tick bite, let us know, because we need the data related to the change in your alpha-gal IgE test after tick bites. And it's an experiment that no one wants to do. We don't put ticks on patients who already have the alpha-gal allergy, because it tends to make their alpha-gal IgE go up. But occasionally patients naturally acquire tick bites, as this participant did, with 50 bites, again, on her leg from larval ticks, which is shown there in the red bar. And then serial blood tests after this show a progressive rise and then a fall in the alpha-gal specific IgE. While this is convincing data to some extent, it's very difficult for us to collect these individual cases and then create a causal explanation. If you'll go to the next slide, there is some summary data where this is from one of the Japanese groups looking at the alpha-gal IgE level shown on the y-axis, and that number tends to increase by the number of new tick bites shown on the x-axis. But again, this is not sort of cause and effect. This is just association. And if you'll go to the next slide, we finally have published this year a case control study where our group, in conjunction with the CDC, enrolled nearly 300 participants, basically 100 cases of patients who had alpha-gal syndrome and nearly 200 controls, and then asked very specific questions related to outdoor activity, tick exposure, measured their blood for alpha-gal IgE. And I think what you can appreciate here in Table 2 under tick exposure, the number of case patients versus control who reported finding a tick on their body in the past year was much different. 88% of the cases, only 47% of the controls. So it gives you an odds ratio of 11-fold increase in likelihood to develop alpha-gal syndrome or alpha-gal specific IgE antibodies after a tick bite. So really kind of the first solid epidemiologic non-case report data truly linking tick bite as a risk factor for the development of alpha-gal syndrome. If you go to the next slide, this was our working hypothesis and framework about how the whole allergy worked, meaning a Lone Star tick would bite a deer or a dog and then feed on a human, and then that human would produce an alpha-gal specific allergic response, and then that decorates all the allergy cells, and when that same human later eats beef or pork or lamb or venison, then they're primed to have an allergic response. This framework is still fairly accurate in most of it, except we are really starting to feel as though the ticks may not need to actually feed on a mammal and collect alpha-gal from that blood meal in order to be a risk factor. Meaning the ticks seem to be able to create alpha-gal, or at least something similar, in their own saliva. If you'll go to the next slide. So here is a basophil activation test, which is a common test we do in the allergy laboratory, looking for activation of circulating allergy cells called basophils. Shown on the left is tick saliva from Amblyomma americanum ticks that have been partially fed, and the basophils are from a patient who has alpha-gal syndrome. And when their basophils are exposed to the partially fed tick saliva. And I should say these are ticks that are fed on human blood through a membrane. So they're not, these are laboratory reared ticks. They're not feeding on mice or deer or sheep. They're being fed through a controlled membrane. And you can see that those ticks can activate the allergy cells from the patient. And these have never had a blood meal from a lower mammal. So it really argues that there is something in the tick saliva that causes that activation. And in fact, if you look on the right, these are Amblyomma americanum ticks, partially fed through the membrane, but these ticks have a salivary enzyme that has been deleted, and it's a glycosylation enzyme, and we see a marked reduction in the stimulation and activation of basophils from that same individual. This is work that Dr. Shahid Karim, one of our collaborators, has been doing at the University of Southern Mississippi. It's been published, but I think it's worth bringing to your attention, just because alpha-gal syndrome is expanding, and we think that part of the reason for this expansion is that because ticks seem to be able to create this risk on their own, in their own saliva, that each of the life stages may pose a risk for people when they're bitten by the ticks to develop alpha-gal syndrome. So unfortunately, I think it puts more people at risk because it does not, we no longer limit AGS just to ticks who've had a blood meal. And I think that unfortunately is an important point, but one worth thinking about from a public health standpoint. So if you'll go to the next slide, I'll stop here and happy to take any questions. I know that we're up against lunch, but I'm happy to take the questions that we can. Thank you.
Thank you, Dr. Commins. All right, Brian.
Scott, Brian Ledette, SUNY ESF, fascinating talk. And I want to draw attention to the map where it appeared there were focal areas of this, the AGS presentation, even potentially areas that were divided by natural geographic barriers. And I did my PhD work in Louisiana, where we have no shortage of Lone Star ticks, but it seems to be a shortage of AGS reported cases. Do you think that this may be associated with genetic like populations, like specific genetic populations of the Lone Star tick? And I want to caveat this with the idea, some recent idea from genetics that northern populations of this tick may be ancient populations that are founder expanding, especially in like New York, where the southern populations are older populations that are more genetically diverse. What are your thoughts on that?
Yeah, no, I think I appreciate that comment and question. And I would first tell you that I'm not a tick expert. And so my sense of this is that changes or differences in the tick populations make sense to me, because there are these nuances that we see clinically that I don't have an explanation for. There seem to be much fewer cases in South Carolina, for example, than there are in North Carolina. And you bring up Louisiana. I over the weekend heard a very similar sentiment from a practicing allergist in New Orleans. And we've heard similar thoughts from people in Alabama, where there are more cases in northern Alabama, but yet not in southern. So I think there may really be important differences in these tick populations that as an allergist and non-entomologist that I'm not even aware of. I think the other possibility is that, maybe there are some, is it the host or the parasite? So perhaps there are host-related factors that are important, but to me, I think some of the differences in the geography really point to the tick populations. There may be important risk factor differences there. but yeah, we're working with the CDC to try to help explain some of that and figure out what may be the cause. I think you may have a better sense of it than I do.
Other questions for Dr. Commins? Right in the front row here.
Hi, I'm Lauren Edline, SUNY Upstate. You know, listening to you talk from a provider standpoint, the diagnostics on this is kind of a nightmare just because there's so many vague, inconsistent symptoms that can result from exposures to so many inconsistent things. You know, we get so many people coming into the clinic with, you know, vague abdominal symptoms we can't explain. And how aggressive should providers really be in kind of testing for alpha-gal given the prevalence in our area at this time?
Yeah, I think, you know, new onset GI distress in an adult that seems to occur particularly in the evenings, in someone who, you know, who eats beef, pork, lamb, venison, etc. You may run the test. You may want them to keep a food diary a little bit. But I agree. I mean, we see people where the history isn't quite clear, and we often do a trial of, you know, 3, 4, 5 weeks of a red meat avoidance diet and see if we can improve their GI symptoms.
I had another question about your MAP data. How do you explain all of these people in Europe with the alpha-gal syndrome? Do they have Lone Star ticks there too?
I'm so glad you asked that. So it's the same allergy, but different ticks. In the US, the Lone Star tick seems to be the biggest culprit, but it's very clear from the European and Australian data that other species of Ixodes, I say other meaning it's not clear about Scapularis at this point, but Ixodes holocyclis, Ixodes ricinus have all been linked to the development of AGS in other parts of the world.
Over there on that side, and then we'll come back here.
Hi, my name is Jamie Romiser. Thank you so much for presenting here today at this group. I'm actually one of those dots on your map. So I've had alpha-gal twice now. So my question for you is, amongst those individuals who have been bit, is there any progress that's been made to investigate the different characteristics that put people at higher risk factor for actually developing alpha-gal?
Great question. And Jamie, thank you for putting your dot on the map. It's a big help. So what we're finding, the biggest thing so far is that the risk factor most associated in our studies to this point with people who go on to develop AGS is that the site of the tick bite will become red, itchy, inflamed, persistent. Some people will say it will form a hard knot underneath the site of the bite. It's often slow to heal. And for some patients, they'll even say that when they have a bad reaction, that the site of the prior bite is the first place that itches. So we saw beautiful posters from the New York State Department of Health related to rashes in the prior talk. And we, in the alpha-gal syndrome space, we really are seeing these brisk reactions right at the site of the bite. They don't hurt as much as they are red, itchy, and inflamed.
Hi, this is Julie Colvin from Syracuse, New York. I have a question on not trying to get attention away from the tick. I have a fair amount of patients post-COVID have symptoms like AGS. Is that possible? Is there any link between post-COVID with AGS too?
Yeah, interesting thought. I think the short answer is if there is a link, it would probably be due to mast cells, which are allergy cells that are found in our tissues, not our blood, so skin, lung, etc. And activation of mast cells can give people symptoms probably consistent with sort of the post-COVID syndrome or other unexplained post-acute infection syndrome. So we're actually doing a little bit of thinking about mast cell stabilizing medications in that space. So hopefully more to come, but that's sort of where I would think there might be overlap.
Hi, Scott. This is Chris Polino from SUNY Upstate. Appreciate the talk. One question I think a lot of people are probably thinking, and I don't know if you touched on it at all. We don't see a ton of Lone Star ticks here. I caveat that with the word yet. Obviously, I think it's moving into the state. But have you seen similar kind of scenarios with the European data where there are potentially other ticks? You mentioned those kind of northern Wisconsin, Michigan clusters. Is there any other tick that you guys have your eye on that may be presenting with alpha-gal?
In the U.S., I think the jury still seems out on scapularis. I think it clearly can't be a major cause of this, because you're right. Y'all would be seeing a tremendous number of cases in upstate New York. I think what gives us pause is the European and Australian data related to other species of Ixodes. But in the U.S., we really have a sense that Amblyomma maculatum does not do this. It really seems Lone Star related. Couple of potential cases in Maine, and maybe a few cases from out west that could have good data or convincing data that maybe it's not Lone Star ticks. But certainly overwhelmingly seems to be Lone Star ticks in the U.S. and probably the cases that are moving into the Northeast and Northern Central U.S. are just due to the expansion of Lone Star ticks. But again, I think the caveat that I'm an allergist, and there probably are many smarter people related to ticks and tick biology, both in the audience, online, and thinking about this. So I would certainly defer to others.
Other questions for Dr. Commins from North Carolina? I think lunch is about ready. And if there are no more questions from out there in Zoom country or in here, all right, then lunch, I think, is about to be served, and we'll be back in here at 1:40 p.m., please, 1:40 p.m. Thank you, Dr. Commins.